Welcome back to the Off Label with Optimize You podcast. I'm here with Jerry Smith, per usual, and we have a very special guest today, America. He's one of our favorites. Hunter Williams is joining us. Thank you for being here, Hunter.
Yeah, thank you guys for having me. And I'm always excited to talk to you guys, especially with Jerry. I always end up learning way more from him than he learns from me. So,
Well, before these two hijack the entire conversation, because you guys listening to these two talk, it's like they're different enough, but also the same in their nerd level in a very, very good way that it feels like eavesdropping on just the most exciting conversation ever. So I do want to introduce Hunter though. Peptides educator, hormone educator, has a phenomenal podcast appropriately titled the Hunter Williams podcast. We love listening to that, Hunter. I call you the guy of peptides. I love that I love that you're a non-licensed person because for one, you can be a little bit less filtered on some things that you say that medical providers, have to kind of tiptoe around. But I always say that Jerry's lane and our providers, they're responsible for treating our patients. I love being able to educate them. I think it's super important so that they can stand on their own 2 feet when they're talking to medical providers. As I've personally experienced being, in front of an OBGYN who's trying to put the fear of God into me based on very, very outdated information about hormones. And so as patients, I think it's really awesome for us to equip ourselves so that we can have those conversations because it's just a lie that you need a license in order to know your stuff, and you're living proof of that. So we're learning a lot from you, Hunter. Thanks for being here.
yeah, well, thank you guys. I think too to the nature of like medical professionals versus not. It's cool now as we have this age of the internet and people can share their information. I always tell people like I make it very clear I'm not a doctor, and we need guys like Optimize You out there actually doing the work of getting the medications in people's hands, actually advising them. So it's cool that I am just in a place where I get to help people, but I always tell people I'm not a doctor, and you actually need really good doctors to work with, and they're out there. And hopefully if I can do anything, it's actually put the spotlight on, doctors like you guys at Optimize You that can do really good things for good people. So
This is probably a good segue for me to say, those of you that are listening, this is not medical advice. This is not intended to treat, diagnose, or cure anything that you think you have. These are just interesting intellectual discussions. And as Tamara alluded to earlier, I don't care that Hunter isn't a medical doctor or a PhD. I think what he brings to the table is an impressive knowledge base, and I say that I don't accept people into my nerd kingdom very easily, and Hunter's more than welcome to be in my nerd kingdom. So he's an advisor to me for sure, and I love it. So thanks for coming. Let's get rolling.
Yeah.
Where do we want to start? What are we going to start with?
Should start with selfishly because I get this question a lot. Tamara, what do you think about peptides? And I always joke, like, that's like asking, what do I think about food? Because I'm gonna need a little bit more information. Like, can you be more specific? Are we talking about a specific peptide? Do you want to know about like the regulatory landscape? And so, Hunter, I'm sure that you get that question all the time. And so, I think a good place to start would be with the importance of hormones as the foundation and how peptides play a role in overall optimization, and go from there. Since I know that that's something that we can all agree on.
yeah, for sure. I think a good way, and this is something I tell people all the time, is when you look at peptides, which are some popular ones like BPC 157, TB 500, whatever you name it, no one actually has a deficiency in those compounds, right? Like no one goes to the doctor's like, man, I just really have a BPC deficiency or insert X peptide. However, we do know for a fact, and actually at this time, in the day and age we live in, most people walking the planet right now, especially in the United States, have a hormone deficiency. And so when we look at overall health, peptides sit on top of a foundation. And if you were to have a pyramid of overall health or wellness, peptides would be like much closer to the top and would be actually nowhere near the bottom. Because the bottom is your lifestyle. And I know we have to get that out of the way, but like lifestyle is very important. So if you're not doing all the things from a lifestyle standpoint, and then you have hormones because those are our God-given building blocks that we have in our body, they're actually going to enable us to function. And unfortunately, because of marketing hype and probably the prevalence of GLPs and everything, we live in this world now where everyone just wants to jump straight to the top of the pyramid and grab the peptides because it's like the Staples easy button, right? You just smack it and then everything is good. And unfortunately, like that's not how it works. You got to start with the foundation, and then hormones are the foundation. And so I tell people too, like peptides can get you places for sure, But in the absence of hormones, which is going to be most people that are trying to use peptides, the hormones are going to actually be what they're looking for. And then the peptides are going to work so much well after it. So I think it's one of those things that people are seeking, not peptides themselves, they're seeking the results that come from peptides. And a lot of times those results are actually just going to come from the hormones, and the peptides are just like really nice to have, the icing on the cake after the hormones get fixed.
Yeah, like in my brain hunter, everything I remember is like a third grade coloring book in my brain, and I guess what I would say is, uh, if my car broke down and I just kept slapping new tires on it, but it needed an engine, did I really fix the problem? And I see patients all the time, and they come in and they have all these symptoms, and they're like, "Well, I want peptides." And I'm like, "Well, you need testosterone or thyroid or whatever whatever the thing is that they need." Peptides really don't do that. So I agree with you. Sometimes they reach to the in vogue thing because Instagram told them to, and they can get on some website and buy it for $100. But what they really needed is an in-depth workup and a consult with somebody that knows what they're doing with the hormone side, or maybe not hormone side, maybe just to talk about, hey, maybe you should just try diet, exercise, and enhance your sleep before we do anything else. Before we go down this road, and some supplements. So no, I'm with you. But tell me what you think about it. So I've been battling this out in my head for a while. Tell me what you think about the dude or the chick you pick. I don't care which sex you pick. That comes in and just says, "I'm tired." Like, clearly, we're going to start with a workup. We're going to look at the hormones. Tell me from a peptide lane, like, where are we going?
Yeah, it's a very good question, because I think when we look at people today, I will even say sometimes after a person gets their hormones optimized, we all know they kind of go through this honeymoon phase, and it's like, oh wow, that was the answer, right? But it's interesting because I've seen so many people on their journey with hormones, maybe it's 6 months, 12 months, even 2 years later, and they're like, well, I thought that was going to fix everything, and for a while it did, but I'm still like tired at 2 o'clock in the afternoon, or I'm still like having trouble getting out of bed. And the first thing, if I hear someone's like, I've got all my hormone fixed, my blood work actually looks pretty good according to, like what would be considered optimized. A lot of times I think energy goes hand in hand with mitochondria health. And when we look at the health of the mitochondria, to your point, Jerry, of the car, it's like, yeah, it's cool if we can keep throwing new tires on the car, but if the engine isn't working, it's not going to do well. And even when we fix the hormones, I think what's really interesting that not a lot of people talk about, we could maybe nerd out about, is this correlation between hormones and like optimizing those, but then also the end health of the mitochondria. Because think of this, we know, like, I think when people traditionally have thought of mitochondria, you probably think of red light therapy. Like, that was a huge craze for a while. And red light therapy is amazing. Like, I do it usually at least once a week in like a medical grade red light bed. But ultimately, red light is for mitochondrial health, for other things too, but that's really what it's working on. And if you take someone that is on hormones, but all of a sudden now you have these junky, clunked up mitochondria, how much results are they actually going to get from the hormones? They're probably going to feel better initially, but if you don't have a clean engine running, and that's kind of our mitochondria, for lack of a better way to say it, like a clean engine running, I don't know that your hormones are actually going to work as well, because all the testosterone in the world, you could take 1,000 milligrams of testosterone per week, but if you don't actually have the raw materials inside the mitochondria to be able to handle it, I guess like energy dynamics within the body would be a good way to say it, like energetics within the body, it's probably not going to work that well. And so I think that's where it's cool, because peptides, we do have peptides to address that, and peptides that work well to address it.
Yeah, like if this is a puzzle, so if each patient or each clinical encounter you have with somebody you consult with is a puzzle, and each piece of that puzzle maybe is a different size, right? I can't just work the puzzle with one piece, and I may even use some big pieces, but I still have to fill in the gaps with other things. So yeah, I can't say it enough. Like, there's no cure-all, there's no one size fits all, there is no free lunch. You still have to consider the other simple things, like I still have to eat decently, I still have to manage my stress, I still have to hydrate appropriately, I still have to sleep appropriately, I still have to check my micronutrients and like understand the supplement component of this. I got to lift weights, I got to have my hormones right. I may need some supplements with peptides along the way to combat something that happens to me, an injury, an inflammatory state, ATP production. Here we go. You can get into the complex 1 through 4. We can get really nerd if you want to. It takes more than one thing often, right?
Yeah, 1,000%. And I think too, that's one of those things that's, if you look at someone that's struggling with energy, it's like, well, are you sleeping enough? Because maybe you're sleeping or you're not sleeping enough, or maybe the sleep that you're getting is not quality sleep.
Or quality, right?
Yeah, exactly. So it's like, okay, well, is it sleep first? Because that's also going to be what I look at. But then maybe it is sleep. And then we could go more to like a mitochondrial stress issue. And then is it oxidative stress? So it's kind of funny, just anecdotally, I was talking to someone in my coaching group today, and they're like, I'm doing all these things right, but I lost all my libido. And they're like, oh yeah, I happen to be an endurance athlete and train for marathons and triathlons. I was like, well, there you go. Think of the amount of ROS that gets built up from someone doing that type of training, which I'm not like, I've been an athlete much of my life. Like if there's anyone that's all for it, it's for me. Maybe not marathons and triathlons. I'm not much of a runner, but if you take a situation like that, it's one of those things again too, like the hormones can be great. The peptides can be great too. But if you are constantly inducing something that is actually counterproductive to the goal of what you're doing, you probably are going to have something where your libido drops or your energy drops or whatever. And I think in a lot of people's head, they're thinking like, well, I did all of the things right. I listened to the podcast. I inserted X supplement or X hormone to fix it. And I think a lot of times we have to look at like this push and pull of like what the body goes through on a daily basis, and then how that compounds over time. And then eventually like how that's going to be reflected in the end state of the body. And like you said, it's multifaceted. So it's not going to be one thing. And that's what's cool about peptides is a lot of times it can kind of cover your bases, but at the end of the day, they're not going to be a cure-all, especially in the presence of things that could be going on from a lifestyle standpoint.
And I don't mean to jump us straight into somewhere we didn't want to go, but back to the sleep and sleep quality for a minute. I know there's some peptides out there. I could throw out the idea of like D-SIP would be one. Clearly, you could combine that with some interesting things like melatonin, apigenin, epitalin, all the things. Let's talk about some of these sleep-inducing peptides for a moment. Is there good evidence that they don't interrupt the architecture of like delta wave sleep or REM sleep? Do they actually enhance it? Because there's a difference for the layman that doesn't know this, and Hunter absolutely knows this, but I'm talking to the general population of the world right now. If you sedate yourself with something, Benadryl, Ambien, Lunesta, like pick some alcohol, like pick some, just because you go to sleep doesn't mean you're necessarily getting restorative REM or delta wave sleep. So do these peptides that we talk about actually do that or enhance that?
Depends on the peptide. Let's talk about D-SIP for a second. So clinically, literature speaking, I don't know that I've ever come across anything where they actually analyzed, hey, we looked at someone's Oura Ring or a wearable device, and then we looked at light sleep, REM sleep, deep sleep, and how it played out. The benefit of what I do is just like kind of coaching people. I get a lot of feedback. I always tell like one of the biggest benefits of what I have done is that I just hear from a lot of people. And so I get kind of like anecdotal report. And I always say, Jeff Bezos says, if the data and the anecdotes conflict, usually follow the anecdotes. And just again, not to say that the anecdotes are evidence, but in a lot of cases, we can kind of look at those and maybe lead us in directions to where we can actually create evidence or at least have like some substantial evidence base. So specifically with D-SIP, it's kind of funny. I actually will say subjectively of people actually feeling like it did anything, it's probably a coin flip. Like I've heard half the people that take D-SIP say it didn't do anything for them at all. They didn't sleep better. They didn't sleep longer. They didn't sleep deeper. It didn't do anything. And then on the other hand, I've actually seen people say that it was like a miracle and they track it with an Oura Ring or a Whoop or whatever. And they see REM sleep go up. They see deep sleep go up. And so even though they were sleeping the same total amount of hours, they actually saw sometimes doubling of the REM and the deep sleep to like where they had improvements there and they felt much more restored. So I think it's kind of one of those things, probably lifestyle plays a factor. Maybe there's even some genetic or just predisposition that some people have to where they don't have, because if I'm going off of memory here, I don't know that we know of a D-SIP receptor in a sense that like the body's interacting with this at a receptor level like it would some other peptides. And so I think when we look at that, maybe some people just are non-responders to it. We know there's peptides that, at least in the data, like PT-141, 40% of people get nausea from it and 60% of people don't at the same dose. And so it's like, maybe some people just have more of a disposition to do it there. So with DSIP specifically, I think to your point about the architecture, subjectively in my life, I've seen it improve sleep architecture. Nothing major to like where it was life-changing or anything like that. But I also think too, to think about it as something that would be an Ambien version of a peptide, which Ambien is just going to knock someone out to like basically tranquilize them. Yeah, you might get sleep, but then what are the long-term consequences? And to your point, are you actually like improving architecture? I think you make the argument that it's like actually making the sleep architecture itself worse. So I think so from an anecdotal standpoint, I've seen that with DSIP, but also too, I would think about DSIP is probably one player, to your point, in like a group of other things that we would look at, because you could take DSIP, but if someone has either pituitary dysfunction or they're not outputting a lot of growth hormone, they probably aren't going to sleep good at all. And then you look at pineal gland function, which there's another peptide called epitalon that helps with pineal gland function. Maybe a person is exposed to a lot of blue light before bed, or they have circadian dysregulation. Maybe they've been a shift worker. Yeah, you're looking at your phone in bed. Which of us hasn't done that? You know, you're watching TV before bed. And so is your pineal gland going to be secreting the same amount of melatonin? And so I think that's where it's multifaceted. There's other peptides that you could obviously use to help those things and kind of push you in the right direction when it comes to a sleep architecture standpoint. But it's hard to say, yes, definitively, it's going to improve sleep architecture, but I would put it up any day against trazodone or Ambien or any of those things that millions of people are using now just to try to like get a few hours of shut eye.
How about, so we kind of touched on epitalon and DSIP. How about pinealon? Have you seen that one?
Yes. And interestingly with pinealon, so I've seen, again, to go back to like how different people respond, I've seen actually people that take it at night before bed sleep better, but then also some people take it the night before bed, they actually sleep worse. And I'm one of those people. So for me, if I take it before bed, it feels like I just had some caffeine and I end up not sleeping well and I'm kind of restless. But if I take it in the morning, I end up having better sleep architecture with pinealon.
Interesting.
So weirdly enough, like it did do that, but sometimes the timing, depending on how it's metabolized, can affect it. Same thing with DSIP too. Like I've seen people that take DSIP at night, it actually makes them more awake, and then they move to taking it in the morning, and ironically, it ends up improving their sleep from when they take it in the morning. So I have seen that with pinealon. Obviously, that's one. It's a more of considered like one of the Kavinson bioregulators out of Russia, and we know it's working on the brain, probably in a couple different regions of the brain where epitalon seems to be more selective to the pineal gland tissue. But yeah, I think pinealon's great, and if anything, if it doesn't improve sleep, some people take it in the morning and it actually gives them energy, and then they have a better circadian rhythm. So sometimes I wonder too, if it's almost not necessarily addressing sleep in the way we think about it, like, hey, I take this and then my sleep is now enhanced. Maybe it's actually just improving the brain to the point where we're better regulated from a circadian rhythm standpoint so that we are awake when we're supposed to and we're asleep when we're supposed to. And I think modern life probably doesn't do us any favors in that sense, you know?
Probably,
For
yeah.
sure.
Perhaps it's got some sort of undefined secretagogue activity, you know, for some people, or delayed activity, similar to like an IGF secretagogue, but perhaps dose dependent or genetic dependence there. That'd be interesting to see. I'd love to, as the world of the clinical course of peptides unfolds, I'm fascinated with the sleep agents, because I think that's a huge part of the problem with society because of our phones, because of caffeine use, because of, you know, like sleep disruption from your partner snoring, from temperature in the room to everything. So I'm curious about how can I biohack my way into better delta wave sleep is what I'm asking you.
Yeah. Well, you know, it's funny because you say that about the dosing. I think this will be an interesting point for people because we're in this like peptide world where the dosing has really come from a lot of anecdote. Like it's just kind of people guessing. And I think even from the pharmaceutical side of things of like GLPs, do we really know what the best dose of a GLP is long term of like what's going to be?
Apparently that's a moving target. We just had this conversation, Hunter.
You know,
I
like
literally just had an hour-long talk with my entire company about, you know, are we overdoing it, and we need to be more mindful of smallest, most effective dose with these. It's interesting you say that.
Yeah, well, the reason I say is because when you talk about epitalon, there was literature that came out of Russia, and for a long time, people thought that the dose of epitalon was 10 milligrams per day for 10 days in a row. Now, I think in terms of side effects that someone would get from that, is that dangerous? I would lean to probably think it's not going to be dangerous for someone, especially if it's in a short cycle. However, there was actually a study that came out that like went to the Russian literature and was looking around at this. The 10 milligram dose actually was for a compound called epithalamin. That's the crude extract from cows that was then like synthesized into an injectable formulation, whereas the epitalon came a lot further and was basically like synthesized into the same amino acid sequence, basically meaning that a lower dose was much more potent than the epithalamin. It would kind of be like if you had, if you were eating liver, like beef liver, versus actually taking a capsule of the beef extract. Obviously, like you're getting a much more condensed version. So it's similar in terms of what they had with epithalamin and then epitalon. And so they actually extrapolated like, okay, if you look at it, the dose for epitalon itself is probably closer to like 300 micrograms to 1 milligram to get the same amount of potency as you would be taking from the
Interesting.
Epitalon.
The
reason I say that is because I've heard of people taking like 5 milligrams or 10 milligrams of epitalon, which again, I don't think is probably not dangerous. They're taking that higher dose, and then all of a sudden they can't sleep, and they're like kind of like irritated or agitated or like highly stimulated. And I wonder the same thing is like maybe at a lower dose, is having more of this like modulatory or bioregulator type effect. But at a higher dose, it's a much more high pressure chemical signal that then again, maybe not dangerous, but then is also having an unintended effect, which is not sleeping good. Maybe you have too much energy. So I think it's kind of thing where we talk about with GLPs and probably some of these other compounds too, of the difference in how it plays out. And a lot of times might be the dose or how it's applied or what time of the day it's applied, and different doses can actually probably have various different effects.
Interesting. I did not know that. Got to ponder that. So you mentioned earlier, and I'm not sure why we're focusing on sleep again. It's just because of the phase of the moon, I guess. But you mentioned growth hormone and IGF agents. So maybe tie together for the world here. When you take an IGF secretagogue, and let's keep this tame. Let's keep it in the FDA approved vein. So I guess I'm talking about Sermorelin and Tesamorelin. Although we know that ibutamorin is pretty interesting, as is IPA, as is the releasing agents like CJC 1295. Let's talk less about those and more about Tessa and Sermorelin. So you're asking your pituitary to do the release, and you're raising your IGF values in hopes that the down chain effect of that is raising your actual GH, right? Tell me about sleep architecture with that. That's actually that actually is delta wave sleep and improved sleep with those, right?
Yeah. Well, funny enough, talking about sleep, if I was practically going to tell someone, they come to me and they're like, hey, Hunter, I'm doing everything right. I can't sleep. What do I do? Guess what? I'm not going to tell them DSIP. I'm not going to tell them epitalon. Almost all the times I'm telling them tesamorelin. And the reason is, to your point, is you're going further upstream to something that at a tissue level is going to play out much closer to the intended outcome that we want, rather than trying to have this little thing that maybe it's doing something, but in the practical nature of what we're looking at, the tesamorelin can act much more like a sledgehammer for sleep than some of these other things that might hit one area, but might not be like far enough upstream to affect it as a whole. And again, to compare it with like Ambien or Trazodone or something that somebody would use for sleep, I would much rather have someone take 1 milligram or 2 milligrams of tesamorelin before bed. And I will say, with like the anecdotes that I've seen, 80 to 90% of the time is going to give them the better sleep that they're wanting. And again, improving the architecture, because in a lot of cases, once someone's 40 or 50 or even 60 years old, how much IGF are they getting out of their growth hormone? Like how much growth hormone's coming out of the pituitary? Well, we know that could probably be improved. And if it's pretty low, like sleep a lot of times is not going to be what it can, even if you're doing everything from a sleep hygiene standpoint, right? So it's funny you bring it up, because that's always the first one. Like a lot of times people, they have these word associations with peptides in their head, and it's like BPC healing, like GLP, fat loss, and tesamorelin immediately, I guess people think growth hormone, but a lot of times they're just thinking fat loss, testosterone, visceral fat.
Not sleep.
Yeah,
Yeah, and in a lot of cases, it's like, yeah, visceral fat loss is a nice byproduct, but how much of that actually comes because we're restoring that whole pituitary cycle that then creates the downstream effects that leads to better sleep, which then is going to create a favorable environment for visceral fat loss.
fascinating. I don't know. I've been meaning to ask you what your thoughts are. Great context here. So, yeah, I like it for sleep. Yeah, I like it for leaning and some muscle building attributes. Talk to me about some insulin resistance that happens with these things. So, you've seen the proverbial HGH belly guy in the gym where he's lean everywhere, he's muscular, but he's got this like visceral looking fat right here in his like belly button level. Talk to me about insulin resistance with IGF agents.
Yeah, it's a very real thing. And I want people to, like, when they think about this, understand that it's going on, but then also understand too that a lot of it comes back to the end user. And so, like, if you were to give someone like this, I kind of use this example. Let's say that I wanted to be a couch potato blob person. What was that movie, Wall-E, that just had the blob people? Like, I'm just going to sit on the couch all day. I'm going to eat snacks and I'm not going to do anything. If I'm not doing anything and I'm not exercising, definitely not taking testosterone, not eating healthy, sleeping healthy, doing all those things. If I inject testosterone, you know what's going to happen? I'm going to get insulin resistance. Like, I'm actually probably not even going to get the visceral fat. I think if you take someone that's not doing the stimuli in order to create the fat loss, all the testosterone in the world is not going to do anything. And in fact, to your point, it's actually going to create insulin resistance, which then is going to, maybe in the short term, it creates a little bit of fat loss, but in the long term, the insulin resistance will end up leading to more fat accumulation. And so I think of it like this, like we think of like testosterone and growth hormone having this really cool 1 + 1 = 3 effect. And whatever the means is that we do it, we know if we optimize them, it's probably going to work better. So if I have testosterone and then I have an agent to raise growth hormone, those things are going to work better together. Conversely, if I have growth hormone and I don't have testosterone, I think a lot of times what you see is this proclivity to create insulin resistance, which then can be made worse in a lot of cases by testosterone deficiency, by lifestyle, by not eating healthy, by doing all those things. And so I think in isolation, you would absolutely say testosterone creates the insulin resistance. I think where people miss it is this, like, yeah, but it was never created to cure insulin resistance. And also too, you don't want to make the mistake of going like, oh, well, now I'm just going to take metformin and it goes away, right? Well, it's like, maybe you could do that. It might not be the worst thing in the world, but it also would be beneficial too if you went and exercised. And I think to that point, it's like, I've rarely seen someone create insulin resistance if they're doing, the pillars right, like their hormones are optimized, they're exercising, whatever, and then they put in testosterone. They're actually going to probably move the needle in the other direction to like where they become more insulin sensitive. But if you were to remove all those things and then put the testosterone in isolation, I would say absolutely, like, you can definitely raise blood sugar. And so again, maybe it's like, are those things offsetting it, or is it that the testosterone works better in the presence of those things? Maybe it's a chicken or the egg question. But I think from what I've seen in people that aren't responsible, it's definitely a real thing. And you could, say that I've seen like A1Cs, fasting blood sugar, probably even a little bit of fasting insulin too, go up from people that are just taking that and not doing things to optimize their hormones or exercise or whatever.
Do you see that happen on a linear, like kind of 1-to-1 with actual direct HGH therapy? Is using testosterone at, say, the 2 milligram dose create about the same amount of transient insulin resistance as like a couple IUs of growth a day, you think?
Probably. Yeah. I mean, like, I kind of think in terms of how it plays out, I think there's like 2 milligrams of testosterone seems to have a very similar practical effect as like 4 IUs of HGH. Meaning that, like, I think a 2 milligram dose is probably going to track, in my experience, with a little bit higher dose of HGH, and maybe like the 1 milligram feels closer to 2 milligrams. Again, that's probably person dependent too. Like, a woman might not respond that the same way as a man would. to that. I will say from the insulin resistance standpoint, yes. Meaning that I would actually say, and maybe we could get into this too, because it probably has to do with like IGF binding protein 3, of like a lower dose of HGH tends to create better results with less insulin resistance than maybe tesamorelin does at a dose that would create the same total IGF-1 levels, if that makes sense.
Yeah.
So that's a cool question to think about, because it's maybe like, for lack of better say, it's like, does free IGF correlate with a better response from a metabolic standpoint? And we look at like insulin and
Yeah, we've kind of hinted around that in the past, you and I don't know the answer. It's somewhat rhetorical, but I think in the guise of, as we all probably listening to this know, bound hormones don't do anything. You know, they're waiting to be released. So does IGF/GH follow that same mantra? That's an interesting topic.
Yeah, for sure.
I have a question for you, Hunter.
Yeah, go ahead.
So, kind of switching modes a little bit. We talked about, people coming in hot, wanting to start with peptides and our perspective on that. This is where I think it gets really fun, and I can speak from personal experience on this, but for people who've been on hormones a while, they've seen improvements, feeling better, looking better. It's like what I like to call the fun phase, like where you're like, oh my gosh, I'm sleeping, I have energy, all these things are better. How much better can I feel? Like, what kind of fun can I have? What are, maybe pick a couple of your favorite stacks for that. We'll call it like that next 5%, 10%.
Yeah, I think I kind of like, there's 5 buckets I like to address first. And it's really easy. It's hormones first, like testosterone, then thyroid, and then some sort of growth hormone agent. And then something like a GLP. It doesn't have to be all GLP, but basically like something to improve insulin sensitivity. And then lastly, a mitochondria peptide like SS31. And then after that, that's where it gets fun, because once you get like those buckets in order for most people, they feel good and they're like, okay, now how good can I really feel? And I think it would come down to the person. So let's maybe take someone that likes to exercise a lot. I think from there, they'd be like, okay, what can I do to maybe improve performance or improve stamina in the gym? I really like something like MOTS-C. MOTS-C can be great because when you're on it, SS31 has this really nice way of just kind of creating a really good baseline. I wouldn't say that there's a performance enhancement benefit of it though. Like no one takes SS31s like, man, I just feel like I'm going to crush my mile time today or go bench 400 pounds a day or whatever. Whereas MOTS-C, in my experience, seems to have much more of this like performance enhancement benefit, whether it's for cardio or weight training or anything that someone would do. And I think I've heard a lot of people say like, man, when I'm on this, like I just don't get tired at all. And so it's one of those things I really like for people. I'd like to start them on SS31 and then go into MOTS-C from there. Then you have like kind of the cognitive side of things too. So there's some cognition peptides. I think a lot of people, especially if they're entrepreneurs or own a business or whatever, they're in situations where there's a lot of mental stress on them. There's what would be called like nootropic peptides. So there's ones like Cmax and then C-Lank, which are more or less just kind of like driving dopamine a little bit more. C-Lank acting more as an anxiolytic to help calm. But when you combine them, you kind of get this nice like drive, but then also a calm, focused drive as well. And I think for someone that might be in a situation where there's a lot of mental stress or kind of multitasking that goes on, that actually creates stress on the brain too. And so those can be very powerful at doing that. So I like those. There's even another one that is called SLU-PP332, which is kind of an exercise mimetic. I've used that extensively for a couple of years, had a lot of people that I've coached that have done it. And that one too is kind of one of those ones. It has a really nice, seemingly like recomposition on the body, meaning like helping people gain muscle, build fat, but then also on exercise performance as well. So those are some, just to name a few to kind of get started. I think it kind of depends on what bucket someone might say like, hey, I want to feel it more. Because I think once they get to the body fat levels that they want and then the energy levels that they want, they're kind of like, well, think I want to be smarter now, and maybe I want to do that. And so sometimes that's the nootropic peptide, and then sometimes too, maybe it's for a performance goal or an athletic benefit or something like that. And I really like the MOTS and the SLU PP332 seem to do.
Those are the two buckets I hear the most often. Is like now, how many muscles can I have, or how strong can I be, or how smart can I be?
Yeah.
Obviously, the IGF agents like Tessa, enhancing mitochondria, I guess, an avenue of going to burn fat because of you expending more energy. What else you got in the fat burning world? I mean, tesofensine was a while, that's been out for a while. What else you got in your pocket for fat loss?
Tesofensine is awesome. It's kind of one of those ones that it came around probably like 3 or 4 years ago, and a lot of people had it, and then the GLPs took off. And so everyone was like, oh, well, this isn't as good as the GLPs, so I'll just get on those. What's cool about tesofensine is I think, one, if you look at appetite suppression, in a lot of cases, it can work really well to suppress someone's appetite, independent of the GLP-1 pathway, mainly probably through neurotransmitter improvement with like dopamine and serotonin. So just kind of elevating those a little bit. It's interesting to think about because one of the biggest issues I think that you're going to see in the next 5 years is people being able to get the weight loss that they need from GLPs, but then also losing muscle in the same vein. And I mean, you could argue, like, is it more dangerous to keep the excess weight on than to not? Probably not. Like, it's probably healthier to get the weight off and run the risk of losing muscle, although I don't think that's what you want to do. And so what's cool is like there's a lot of compounds in development right now that kind of operate independently of the GLP pathway that would create the loss of fat in the body while also retaining muscle. So one of them, and who knows where this will go, and there's also like analogs of this that are coming around. One of them is called ATX 304. And basically what that is an AMPK activator. But unlike other AMPK activators like metformin, it doesn't seem to have an effect on IGF-1, and probably we'll find out more as it gets more and more studied. Doesn't seem to inhibit mitochondrial function the way that metformin does. So it's activating AMPK, and I think in the most recent human trials, like 400 milligrams a day over 30 days, people had an 8% increase in base metabolic rate. They had a drop in triglycerides. I forget how much, but there was a drop in triglycerides, a drop in liver fat, but they lost no lean mass. They also didn't have an increase in heart rate, so it wasn't like a stimulant-based thing. Like, there's like the old like ECA stack with like ephedra caffeine and, I forget the A of the ECA stack, but some of those ones that like you
gas station products.
Yeah. you'll take, but then you'll have tremors, for the rest of the day when you're doing them. So I think that's one that's really cool because it's working independently of that. And then when you create fat loss without the muscle loss, it's pretty cool. And maybe as a way that someone could supplement a GLP, maybe not have to be on as high of a dose of a GLP and get more of the fat loss via different avenues rather than just kind of hammering the GLP pathway, or even in the case of tirzepatide, the GLP and the GIP pathway. So I'm excited about that. There's another one called BAM15. That hasn't been studied in humans yet, but there's a rodent study where they looked at BAM15 versus semaglutide and tirzepatide. And what's interesting, they gave the rodents BAM15, SEMA, and TERS. They all lost the same amount of weight, or like roughly the same amount of weight, but on BAM15, there was no loss of lean mass versus SEMA and TERS. Obviously, there was a substantial portion of the weight loss that was lean mass. And so that one's a mitochondria uncoupler. And so whether or not that's like a pathway that would be smart to go down, who knows? Like, it doesn't seem to have bad side effects when I've heard from people using it. But also, too, it's just one of those things we don't know what we don't know yet. I would probably lean towards ATX 304 from like a mechanism standpoint, being safe. And obviously, we have human data on it thus far. But yeah, I think those are really cool things because, one, they're operating independently of GLPs. Two, they also are creating fat loss without the lean mass loss. And then also, too, like it's not blasting one pathway that you become so dependent on. So whether it's those two, tesofensine, obviously I'm a big fan of tesofensine, and there's actually clinical human data on real weight loss from that. And we know, I forget the numbers, but it doesn't seem to have as high a proportion of lean mass loss as some of the GLPs do. So there's lots of stuff out there that is not as popular because it might not be as dramatic, but could actually, for the long haul, be something that you could sustain better weight loss on without the threat of the muscle loss.
How do you feel about, so same combo, the different substructures inside 191 amino acid HGH, this 5' arm, so like AOD 9604 seems to have fat lipolysis properties. Is that something you think is true, or mostly snake oil because of the half-life?
Well, I think in isolation, I've rarely seen it do anything in isolation. And so take someone that's never done anything, never done a GLP, whatever, they take that. Most people aren't going to notice a benefit. What it does seem, though, to do is people that are doing a GLP, that are also doing a GHRH like tesamorelin, and then they add in the AOD, I think it actually progresses them maybe like 5 to 10% more than they would get without it. And so what I tell people, kind of going back to the sleep equation, does taking DSEP fix people's sleep? I mean, some people it might help, but in most cases, it's not going to fix everything. But if you combine it in on top of everything else being there, I think there's probably like a synergistic effect that is going above and beyond. And so maybe it's one of those things like it's the fragment of growth hormone that by itself doesn't do anything. But if you have increased growth hormone levels and you throw that little fragment on top, maybe it works a little bit better to get the fat loss out of it. Also, too, kind of like the anecdotal bro science thing would be to take it in a fasted state before cardiovascular exercise, because you're going to get the movement from the cardiovascular exercise and an increased beta oxidation that would then probably help with the fat loss a little bit more than if you just took it, if you ate a hamburger in the middle of the day and just didn't do anything. You probably get a little bit more benefit out of it that way too. But you know what's interesting, Jerry, and I'll have to read this because I didn't read the whole thing. There was an article that just came out that talked about intra-articular injections of AOD 9604 actually being beneficial to regrow cartilage for people. And what's interesting is I don't know what would happen if you would do an intra-articular injection of tesamorelin. Like, I don't think anyone's ever looked at that. And I don't know what caused someone to want to do this, but they did it in humans, and it did seem to have at least a better than placebo effect on actually increasing like cartilage regrowth there. So I don't know if that people end up injecting. I've never done that myself to like help with an injury, but it is weird that was looked at.
I've never heard that. That's interesting. But I mean, it would make more sense to me with AOD in that it's an actual fragment of growth hormone, whereas test as a pituitary stimulant. I wouldn't think that it, as a prodrug itself that has an action on the pituitary, would have much local tissue effect in the knee or in a shoulder or encapsulated joints in general. But I guess I'll stand by and wait for some more literature to roll out. Okay, one more, then I'll defer back to Tamara to lead the discussion here. Give me your hot take on this. So I just recently heard some emerging literature about how if you pitted GLP in the recommended big pharma doses against extreme calorie deficit diets and also against gastric bypass surgery, that all three have a very correlated amount percentage-wise of muscle atrophy. So it's not like the GLP had more exaggerated atrophy than, say, just caloric restriction did to some degree. Hot take on that. What do you think about that?
I think it's very accurate, because people ask me all the time, like, what are the long-term implications of GLP use? And then I want to retort to them, well, what are the long-term implications of starving yourself? Probably not good, right? And the GLP is making it easier to starve yourself. And to your point of like whether it's gastric bypass or just extreme calorie deprivation, I think that GLP is an enabler, meaning that, yeah, you can use it to lose weight and starve yourself, but are the side effects really from the GLP, or are they really from the fact that your body went into starvation mode, that then it just, all the things that would have happened in starvation mode anyway tended to take place? And so I think what's interesting is I don't think ever before we've had a population-wide thing that enabled so much weight loss across so many people. Like, I don't think there was a fad diet or a supplement or anything that like enabled the fat loss and the weight loss that GLPs have created. And so we see the consequences of what has happened with that. And it's like Ozempic face or Ozempic butt or whatever. It's like, if all of a sudden you had this magic pill that just made people not eat, would all of those things happened anyway, it's the consequence of the behavior that results of the drug, not necessarily the drug itself. And I think a good way to think about it is like there's the old saying, it's like history doesn't repeat itself, but people do. Like human behavior repeats itself. And I think it's just like one iteration of like, this is just another tool that enables humans. And there's also the old saying, like humans can't have nice things. Like you just can't have nice things. It's like you give them a nice thing to like actually enable them to do it. And what do? Rather than dieting and exercise and being hormonally optimized and lifting weights and doing all those things, in addition to the GLP, they just take the GLP and then they starve themselves. And then you see it play out there. So I would be much more in the camp of that makes sense, because it's like, it's just another tool to enable weight loss, to which then people will do unintelligently in most cases. Like they don't change to eating, like chicken and rice. They just eat less pizza. And it's like, well, if that's what you're going to do, then it probably will play out like that. So I would be more on the, like it probably is just bad human behavior that's causing the weight loss.
That's another conversation I have all the time, Hunter, because I'm a woman with a lot of female friends all over the spectrum, especially in the gym or in the sauna. That's where all the conversations take place, it would seem. But people who either love GLPs and think they're the most amazing advancement ever, and people who hate them and think that they're ruining society. And I'm always like, I agree with both of you, depending on how they're being used. But since you're a fan of anecdotes, I'll give you my anecdotal experience. I took one of your suggestions you presented at the conference and basically cut paste it, and little baby dose of tirzepatide, and I have continued to gain muscle. But same thing, like I broke it up into twice a week, and then when I was tolerating that well, I tried it just once a week and had a little bit of heartburn for a couple of days, eating the amount of calories I know that I need. So broke it up again, and it's been smooth sailing, and I just love that technically I am taking a GLP, I'm on tirzepatide, and I'm gaining muscle.
Yeah, I think it's actually probably the underappreciated case is healthy people that make themselves healthier with it, because you're already doing everything from like a habits and lifestyle standpoint. And then you add that in and you get this really nice like background inflammation suppression, improvement a lot of times in cognition, because obviously you're improving that. And I think when we look at anti-aging or longevity, because longevity is like the buzzword now, how much of aging is driven by the decline of the insulin cycle in the body? Meaning that as we age, even if you controlled for everything that you do, how much of like the decline in insulin sensitivity that is accounted for strictly by a person getting older, not lifestyle, not diet, but just a person getting older, not having the same insulin sensitivity as they did when they were 20. I think if you were to actually look at that, maybe like something like tirzepatide, because of what it's doing, is actually like a reverse aging tool if it's used intelligently. Obviously, the difference would be the dose, but if you're using it intelligently, a lot of times I tell people, you actually don't want the appetite suppression from the GLP. So if you don't feel an appetite suppressing effect, that could actually be a good thing. Now, you don't want to go binge eat and like, drink a bunch of beer and eat pizza all the time and stuff. But if you actually are not feeling anything, that could be a benefit, meaning that it's working in the background to have this improvement in all these underlying things without actually having an effect on the way that we have our behavior, which hopefully is healthy, to the point that I'm creating all those bad side effects that so many people complain about.
Yeah, it's interesting because like you said, it's kind of running in the background, and I feel that because I didn't really feel appetite suppression necessarily. It's more like I looked back and I was like, well, I'm gaining muscle, but I'm also losing a little bit more body fat. What's happening? I don't think I'm eating differently. And I kind of did the math, and I don't have a sweet tooth during the day, but at night I have a nightly ritual, or I had a nightly ritual where I have something very sweet like right before bed. And I just haven't had the tolerance for that, or the urge for that in a couple of months. But it's like you said, it's just not something that feels super obvious. I have to kind of scratch my head and look back and think, what's changing about my eating habits, and it's just that tiny little sweet treat before bed.
Yeah.
So we're like, well, go ahead, Hunter. Sorry.
Well, Jerry, I actually wanted to ask you this because Tamara brought up the split dosing versus the once per week dosing. And so I get criticized a lot because people tell me that our like the people that love us so much at Eli Lilly recommend for tirzepatide to be done once per week because it has a 7 day half-life, which I don't think someone is harming themselves. And I actually did that for years before I kind of moved to doing the split dosing because it was like, oh, it's 6 day half-life. You take it once per week. What are your thoughts as a medical professional around, okay, I have a product that has a 6 or 7 day half-life, which means you can take it once per week and technically it's going to be there, versus even if you just did it in 2 doses. So you took the same total dose, but just broke it up into every third day. So like, a Monday and a Thursday. Is there like basis in actually doing that to how it would play out from an effect standpoint? Or are we just kind of like splitting hairs and so like it's really not that important to split it up?
Well, this is a loaded and probably deep question that I could make several points about, but let's just talk about some other drug. Let's just take the GLP out of it for a minute. Let's talk about testosterone in that setting. Testosterone cypionate traditionally, by proxy has been dosed once a week. But what we know about that dose is it's about a 2 day window to peak, and somewhere around day 6 or 7, you have 70-80% decline. So I guess I would ask you, would you prefer to hang out at a more stable upper quartile level, or would you prefer to have it all in the first few days and then in a peak and trough distribution really drop out in the last few days of the dosing cycle, and then ramp it back up to massive doses again and ramp it back down to the bottom third quartile towards the end 2 or 3 days of your dosing cycle? I think probably GLPs kind of follow that mantra. One difference would be where's the threshold of beta cell sensitivity change. So did I get enough to truly change the function of what I'm trying to address? But in general, I think smaller, more frequent doses is better with about anything you want to talk about than one big dose that lasts over per unit time. Because your body doesn't make GLP once a week. Your body makes GLP constantly, based on caloric intake and activity and all kinds of factors there. So I think that it's not unwise to split your dose if you're willing to inject that often and do moderate small doses as opposed to one big one. Not that the one big one can't work. It's just that you may experience different outcome and side effect profiles with smaller, more frequent in a beneficial way, to be honest with you.
Thank you.
Yeah, I mean, I'm much more of that opinion too, because to your point, I kind of brought that school out of thought out of the testosterone because I feel, like you said, better in the upper quartile where it's more stable and I'm not having these peaks and troughs. And what I noticed is when I would do tirzepatide, because I was doing it years ago with tirzepatide once per week, I mean, it changed my appetite, but I would go on this roller coaster to like where during the week I would have kind of like an uptick in appetite suppression. So maybe if I took it on a Tuesday, Wednesday, Thursday, and Friday, I would have this like wave of like no ability to eat. And then Saturday and Sunday, it would kind of come back. And I wouldn't say voraciously, but to the point of like, oh, now I'm really hungry. And so I kind of was like, there were days when I was like really hungry and then days when I wasn't hungry at all to the point of almost feeling sick. And then I just moved to splitting up the dose, even the same total dose of a low dose, even if it was like 2 milligrams or 3 milligrams a week. And then just broke that up into 2 or 3 shots. And all of a sudden I was like, oh, I just kind of feel like a nice normal feel to where I don't feel like nauseous, but I'm also not like ravenous at the same time. And I was like, well, for me, that's a lot better because I just want to feel normal all the time rather than feeling like I'm on a roller coaster, which I think if to the point of testosterone, you're going to feel the same way. It's like, hey, if you do 1 shot per week, probably going to feel good for a day or 2, and then you're going to come back and then feel like a decline in all of the effects that it has. So, yeah, I've heard people have accused me of saying that like, well, you'll burn out your receptors by injecting too frequently. And I was like,
There's no evidence of that.
Yeah, I was like, I don't know that the receptors necessarily work that way, that the more frequent you inject, that you're going to burn them out. If anything, I think you might increase the like maybe the density and sensitivity. It seems like with testosterone at least that over time, like when a person has accumulated, like obviously I know it's a hormone, so it's different than the GLP, but it seems like guys that have been on testosterone for years can handle more testosterone without side effects because they've acclimated themselves to it.
There's a lot there, yeah. I mean, not directly apples to apples, but with an androgen, for that first 6 to 8 weeks, you're getting an upregulation and then androgen receptor density for sure. And then there's kind of this like cap where you're making them about as fast as you destroy them. But for 100% sure, when you start increasing your testosterone levels, you become more androgen receptor dense over a unit of time than if you never were exposed to above your baseline. I don't know that that's true for GLP or its receptor mechanisms. This is what I'd like to have a whiteboard behind me and draw you what I mean. But in terms of these serum levels, it would be a different context if I said, "Hey, I have a kidney stone and I need pain control now, but I don't need it next week. So you give me a drug in pulsatile fashion, one big dose. I spike up my concentration in my serum of the drug, and then it tapers off, and maybe I don't hurt anymore for that because I passed the stone." As opposed to these agents we're talking about, I need these in chronicity. I need them not just today, I need it tomorrow and the next day. So a smaller, more frequent dose makes a sine wave more smoother, curvilinear distribution from the highs to the lows, the peak to the nadir, than say a 1 time per week dose would. So yeah, I don't know that there's evidence of receptor tachyphylaxis or burnout with GLPs. I don't know that that's true, and I suspect it's not.
Yeah. I mean, I haven't seen what I would call burnout. Of course, if someone does 2 milligrams, eventually, if they need to keep losing weight, sometimes they have to go to 3 to 4 to 5 to 6 over time. I think there's a case for that. I've actually, like, philosophically, and I kind of stole this from the bodybuilding world. There's the old, like, concept of blasting and cruising from the bodybuilding world, to like where they cruise on their TRT dose and then they'll blast if they need to go through a growth period. And I'm big on cycling peptides, obviously. And what I've seen through the years is that GLPs, like, people are healthier with them than when they don't have them. And so I've shifted my mindset to be more of like, I still think you should cycle them, but I don't think it needs to be to the point of like only like very strict cycles of like 8 weeks here and 8 weeks off. Like, I think someone could probably go up to the dose that they need to, especially to get excess weight off if they're like dealing with a weight issue. And then when they get there, then they can come back down to a very low dose and then maybe take, 1 month or 2 months out of the year where they're not on it and they build up some more receptor sensitivity. That's kind of where I've shifted my philosophy, where I've never really used GLPs for weight loss per se, because I was never in a place where I was like, I need to lose weight, but I've used them to enhance my health and control appetite and do all those things. And what I've noticed is that it seems to work really well. If I have a phase, maybe I want to like lean out for the summer or something, I'll take up the dose for maybe like a 4 to 8 week period, kind of exist in that therapeutic dose that I'm going to get the weight loss that I need. I get there, then I titrate it down, go to like a microdose of maybe like 1 milligrams or 2 milligrams per week. And then I sit there, and then maybe I take a month off there and I just kind of chill with nothing. And I go back on a microdose. And if I need to lose weight, I can take it up. In a lot of cases, I don't. And so I just chill at that microdose. And I've gone much more to that of like blasting and cruising type effect, rather than like, okay, I'm going to do this for this time and then come off of it, and then people are always, they're complaining now, but like, oh, well, what happens when you stop the GLP? You just rebound weight. It's like, well, yeah, because you don't have the same appetite suppression. But in my experience, if people are actually continuing to exercise and diet and live healthy, I don't really see like a regain in weight. Of course, you're probably not going to be as lean as you would be on it, but in a lot of cases, like there isn't the rebound weight gain for those people that control for lifestyle variables.
No, you're right.
Well, I think you just gave us the title for this episode we just recorded, Blast and Cruise. So thank you for that. This has been so fun, Hunter. I hope we get the opportunity to do as many of these with you.
I feel like we didn't get anything else to talk about. It's been an hour during like the last 45 minutes. Here's what I'd say. This should be like part 1 of a 2 or 3 series thing, if Hunter's willing. But again, thank you for being here. I'm always humbled by your knowledge, sir. Thanks for doing this with us.
Yeah, likewise. And as many as we want to do, I'm game to keep doing them. So definitely would love to continue more and just help get more information out there.
Well, thank you, Hunter.